Hi, my name is Yaria Bangura. I'm a student at Maryview University. Um, my topic focuses on the impact of implementing the post-traumatic stress disorder checklist for DSM-5 PCL-5 at the psychiatry clinic. Um, want to say a big thank you to the committee members, my chair, Dr. Joanne Khan, Maryview University faculties, and second reader, Dr. Boniface Stigman. Introduction. So, post-traumatic stress disorder. Undiagnosed, and untreated patient with post-traumatic stress disorder, which leads to debilitating outcome and even death. Guidelines recommend routine screening for post-traumatic stress disorder for patients with anxiety, depression, or both, age 18 to 65, during their psychiatric clinic visits. The clinicians can screen and identify patients with post-traumatic stress disorder, although their engagement and the studying was low. To mitigate change, it is essential to address this growing concern, which will improve PTSD outcome and globally unified. The purpose of this project to implement PCL-5 screening tool in an adult psychiatric clinic and evaluating its effectiveness in improving early identification of post-traumatic stress disorder. And also documentation and referrals of patients with post-traumatic stress symptoms to determine if the screening tool increased post compared to pre-implementation referrals for psychiatry treatment, and also if education was provided as necessary. Background. Post-traumatic stress disorder affects approximately 6 to 8% of adults in the United States each year, and up to 30% high-risk groups such as those with trauma exposure, chronic illness, and unstable environments. Post-traumatic stress disorder often goes undiagnosed in primary care and also psychiatric clinics, leaving many patients without needed treatments. Standardized screening improve early and accurate identification of trauma symptoms. Prior to this project, the clinic did not have a formal PTSD screening workflow. The PCL-5 is a validated evidence-based tool that enhances detection and guide timely referral to mental health services. Guidelines recommend routine screening for PTSD in patients with depression, anxiety, or both in psychiatric clinic, which aids in accurate diagnosis, treatment, and follow-up care. Research shows that effective screening programs for post-traumatic stress disorder utilized in psychiatric clinic setting have resulted to improve mental health outcomes. The significance: post-traumatic stress disorder commonly unrecognized in primary care, leading to delayed diagnosis and poor health outcomes. So that means a focus needs to be placed on recognizing and diagnosing patients with post-traumatic stress disorder as clinicians. Early screening improve identification, enable timely evidence-based treatment, reducing symptoms severity, and enhancing quality of life. The PCL5 is a validated, reliable tool that increases detection accuracy and support consistent clinical decision making. Implementing standardized screening, strengthen trauma-informed care, improve referrals pathways, enhance coordination between primary care and mental health services. The aim for this project is to implement the PCL5 and evaluate its effectiveness in improving post-traumatic stress disorder recognition, documentation, and referral to mental health services among adult primary care age 18 to 65. Practice support. The clinic staff, which include the psychiatry, mental health nurse practitioner, psychiatrist, administrator, and also the Merriview Institutional Review Board and Committee, my DMP chair, and Merriview faculties. Benefits to practice. So enhancing early detection of PTSD allow providers to address trauma-related symptoms before they are worsened. It's very important. Improves continuity of care by strengthening referral pathway between primary care and mental health services. Support trauma-informed patient-centered care by giving clinicians a structured and a validated tool for assessment, which is the PCL5. Increases provider confidentiality, consistency in screening, documenting, and managing PTSD symptoms. Some of the literatures that was used in this, some of the literatures that were used. So PTSD prevalence, it was 6 to 8% of adults, higher in vulnerable population. Underdiagnosed up to 50% in primary care, and psychiatry patients with PTSD remain unidentified without structural screening tool. That's why the PCL5 needs to be used in the clinic to catch this population that needs help, that has PTSD, that is undiagnosed. So the PCL5 validated high internal consistency, strong correlation with the CAP5 golden standard. Benefits of routine screening. What are the benefits? Early intervention improve outcomes, patient outcomes. Better communication between primary care and behavioral health also improve patient outcomes. Barriers identified in literature. Staff time constraint, because there was staff time constraint and limited mental health resources, and patient resistance, stigma, fear of disclosure of their trauma. Facilitator, So training was done, workflow integration, electronic health record prompts, and administrative support. Theological theo, theo, theoretical framework theoretical framework that was done during this project was the Ken 8 change model that guides this quality improvement project. So it established urgency based on the need to improve PTSD screening, formed a guide coalition between primary care provider, mental health staff, and clinic leadership. Develop and communicate a shared vision for standardized trauma screening. Reduce barrier with staff training, workflow adjustments, and also standardized scoring and instruments. Implementing short-term wins, such as improved documentation and increased referrals. Anchor change by integrating the PCL5 into routine triage and annual visits. This framework ensures structure, stepwise, and sustainability change within the organization. Method and design. Design was a quantitative explorative design through a retrospective chart review, which were 100 chart, 50 for pre, 50 for post. Electronic health records was used. Setting was in a psychiatry adult clinic focusing on age 18 to 65. Intervention was routine administration of the PCL5 during clinical encounters. Implementation step: staff training on PCL5 scoring and interpretation. Workflow redesign to incorporate screening at intake. Documentation template for scoring and referral. Post-implementation evaluation after screening integration. This design was selected because it allowed measurement of change over time aligned with the DMP practice focus inquiry. Sample. So the sample size again, pre was 50, post was 50. Age range 18 to 65. Clinical background, patient with anxiety, depression, or both, age 18 to 65. Data collection include the PCL5 score, referral outcomes, and engagement with treatment. Data analysis. So data analysis, descriptive statistics were used to help the researcher describe the data. It improved the description of data collected during the quantitative research. Pre and post implementation comparison were conducted to evaluate change in screening completion rates, positive PTSD screenings, mental health referrals, treatment acceptance. The demographic variable of ethnicity shows that pre and post intervention distribution as relative similar to African American in both pre and post was high representative group. This distribution of diagnosis was also relatively similar in pre as compared to post intervention, with depression and anxiety as the highest representative diagnosis. Referral rates increased significantly from 10% in pre compared to post intervention with 74%. Results. Increased screening completion from 0% to 80%. That's huge. Higher identification of PTSD symptoms mean PCL5 scores increase from pre to post. Improved documentation. PTSD relative note increased. Referrals, 74% of patients was referred for treatment and 74% accepted the referral, but 14% declined. Treatment uptake increased compared to baseline. So descriptive result. So ethnicity distribution by period. So if you can see the pink, orange, and green. So the green is pre, and the orange is like the pink is like the post. So this is African American, and this here is Hispanic, Asian, and Caucasian. And referral rates for pre and post intervention. So 0.0 refusal, and then there was no refusal because it was just 0. So referral was like 10%, and then 90% was not referred. And then post-intervention, 12% refuse, 14% not refer, 74% was refer and treated. That's huge. Statistical results. Frequency of screening. Statistically, the significant increase in the ratio from pre to post intervention was noted, and then demonstrating a change in one direction. Referrals, there was a statistically significant more ratio for pre to post intervention. However, there was insufficient information to suggest an increase in the ratio from pre to post intervention, or significantly evidence to show a change in one direction. Limitation during this project, the sample size limit generability. Additional clinician workload increase appointment time. 6 post-intervention patients refuse treatment despite referrals. Highlight role of readiness and stigma. Inconsistent staff compliance early in implementation. No long-term follow-up to assess no long-term follow-up to assess sustained symptoms reduction. Discussion. Implementation of the PCL5 improve identification of PTSD symptoms. Very important. Increased referrals suggest better recognition and care coordination. The more referrals, the better outcome and coordinating of care. Workflow integration creates better collaboration between primary care and mental health. Given the outcome of this study, it is hopeful that the clinic will use the screening tool more frequently. Patient education is essential, especially for those who decline treatment. Finding aligned with the literature shows that validate screening to improve PTSD recognition, which is true. Impact for practice. The Quality Improvement Project highlights the benefits for PTSD screening at the psychiatry clinic setting, supports evidence throughout literature, and aids provider awareness for trauma and mental health needs. Improve referral pathway and early intervention. Guide future quality improvements in behavioral health integration. Reinforce trauma-informed care principles. Conclusion. The project demonstrates that implementing the PCL5 in primary care and psychiatric clinics is to improve PTSD screening, documentation, treatment, and engagement. If repeated, greater emphasis will be placed on patient education, deeper staff training, and sustained monitoring. Impact of the DMP journey. Strengthen leadership and system thinking. Enhance ability to translate evidence into practice. Improve communication, collaboration, and project management ability. Reinforce commitment to patient-centered and trauma-informed care. Future work include expanding screening to additional clinics, evaluating long-term outcomes, and develop patient readiness for intervention. Is that a reference? Thank you so much for listening to my presentation. Thank you. If you have any questions, please reach out. Thank you.